Hello, everyone, and welcome to today's Health Policy Issues Group webinar. I'm Arnold Weinfeld, Associate Director at Michigan State University's Institute for Public Policy and Social Research. And as always, we are joined by Kathleen Stifler of Michigan State University's Institute for Health Policy, our partners in putting these together. Would also like to thank the Michigan Health Endowment Fund for their generous support of this program. We have a small group today, so if you have a question, you may use the chat box or raise your hand, and I'm sure that Kathy will recognize you. I'll be watching those as well. This is being recorded and will be posted on our resource page. And with that, I will introduce and welcome Kathy, who will introduce our speakers.
Thank you, Arnold. Thanks for joining today. I will just briefly tee up our topic for today, unwinding the public health emergency, and I will introduce each of our two speakers individually. And we will take questions after each presenter, and then again at the end, either you can put those questions in the Q&A function, or Arnold may open the mics and let you ask the presenters directly. So I think, as we should all be aware, the Secretary of Health and Human Services declared the public health emergency on January 1st of 2020 due to the COVID-19 virus that became a pandemic. And that public health emergency has been renewed continuously since then. And so as part of those sweeping provisions of the public health emergency, rules were eased to assure that Medicaid and CHIP enrollees did not lose healthcare coverage during the pandemic. Now, with rumblings that the public health emergency may end soon, states are being told to begin their preparations for when those eligibility renewals will be required, those reviews. And so there are many things that states are tasked with doing at this point to help assure that thousands do not lose coverage, both in Michigan and across the country. So today we're happy to have both someone, a national expert who can give us the scene of what's going on around the country, as well as a state expert who is up to date on Michigan's plan for preparing for these changes that are coming. So I'm going to introduce them individually at the point of their presentation. So I will begin with our first speaker, Heather Howard. Heather is joining us as professor of the Princeton, of practice at Princeton University School of Public Health and International Affairs, where she co-directs the Global Health Program and is faculty affiliate at the Center for Health and Wellbeing. She's also the director of the State Health and Value Strategies Program, which is a Robert Wood Johnson Foundation funded program focusing on assisting states with transforming their healthcare systems to be affordable, equitable, and innovative. So I will go on mute and I welcome Heather. Thank you.
Thank you, Kathy. Stay on for 1 second just to make sure I'm sharing my screen correctly, okay, right? Sure. Do you see my PowerPoint?
You're good. Thank you.
Excellent. Thank you. Thank you. And Kathy, one thing you didn't mention in my introduction that might be of interest to folks here is that I am myself a recovering state official. I was New Jersey's Commissioner of Health and Senior Services. So I always love being able to speak to state audiences, and loved that work. And that really fuels the research I do now at Princeton and the program I run for the Robert Wood Johnson Foundation, State Health and Value Strategies, as Kathy mentioned. So quick sort of agenda for today to give you a roadmap for my presentation. And I know Kathy will post the slides. So there's a lot of information and there are hyperlinks on the slides too. So if you want to, go deeper on things, you can. But, I want to start by thanking the folks at Michigan State for organizing this, and friends at Michigan Medicaid. I'm looking forward to hearing about all the work they're doing. I know they've been doing a lot of work getting ready for this. So I want to start today with, I'll give you an overview of the public health emergency, talk about what's at stake, why this issue is so important. I think we cannot overstate the significance of the unwinding here, and because it's going to, in a nutshell, millions of people across the country, but tens of thousands in Michigan, will be shifting their health insurance coverage And there's the potential that many will fall through the cracks. And so what we're going to be talking about today are what are those stakes and what can states do now to reduce that churn and those coverage losses. And we'll talk about the context in which states are having to do all this heavy work, and what are some strategies that states can adopt to mitigate those coverage losses. And then finally, I want to wrap by talking about how it's not just about coverage, but it's about access to care, and leave you with some of our resources that perhaps will be helpful as you think about these issues. As I said, the key points are that really the stakes are really high, and I want to ground this in what are the policy goals for the unwinding, which I think are to maintain people in coverage for which they are eligible. That may be Medicaid, it may be employer-sponsored insurance, it may be Medicare, it may be marketplace coverage. And in order to do that, it's going to be really important to have partnerships with outside stakeholders and advocates. That's going to be really important. And I'm going to give you some examples, some Michigan and some from other states and the feds, about how to accomplish these goals. So let's ground it in sort of the recent history of the pandemic. Kathy mentioned the first recorded case of COVID was the end of the year 2019, hence it was called COVID-19 virus. The first US case wasn't recorded until January 20th. And the HHS secretary declared a public health emergency January 31st, but made it retroactive. And then as you follow this trajectory, I think what's key is several federal responses. So you had President Trump on March 6th signing the first COVID relief bill, and then March 18th signing FCRA, which I'm going to be talking about, which is what's relevant today, is the Families First Coronavirus Response Act. That's happening on March 18th. But basically, a flurry of activity, federal declarations, the World Health Organization declaring a pandemic in March 11th, and then several congressional actions providing relief to the states. But the key one we're going to hone in on is this March 18th. And this is the Families First Coronavirus Response Act, FCRA. It doesn't quite roll off the tongue, but some of you will remember this was enacted by Congress, signed by President Trump on March 18th. It did a number of things. It was focused on making sure there was access to testing for anybody, regardless of your insurance status. There were supplemental appropriations to federal health agencies. There was food aid. They created an emergency paid leave program and extended sick leave. So a broad array of responses, but there were a number of Medicaid provisions that were really important. And this first one is the one we're going to be going deep on, is they increased FMAP, which is the federal match for Medicaid. And I've got some slides coming up on that. There was also money so that Medicaid and CHIP could provide COVID testing without cost sharing. You didn't want there to be any barriers to people being tested for COVID. Also using Medicaid as the vehicle to ensure access to testing for the uninsured. So, a broad bill with many provisions, but let's jump into sort of what's most relevant today is that they increased every state's match rate for Medicaid. And so this sub-bullet I have here reminds you. So California and a bunch of states, I live in New Jersey, are what we call 50-50 states. For every dollar they spend on Medicaid, they get 50 cents back from the federal government. Michigan's match rate is higher. And what this new federal law did is it said, we're going to temporarily increase your match rate by 6.2%. So Michigan's match rate now is 70.91%. So for a dollar that is spent, they bill the feds, that they get back 70.91 cents. So that's the benefit of that temporary rate increase. And I just have Mississippi by comparison is the highest match rate is at 84, and California and New York, New Jersey, and a bunch of other states are at the lowest. So it gives you a sense of what the scale is. And it's basically, they said to the states, we're going to give you more money for Medicaid. We're going to backdate it to January 1, 2020, and we're going to continue that extra FMAP money as long as the public health emergency continues as declared by the HHS secretary. We're actually going to continue it through the end of the calendar quarter from when that ends. So I've got this on a thing so you can see it. But basically they're saying we're giving you a lot more extra money and it's going to be tied to the PHE. Now, why did they do this? There are a couple things. One, it was a recognition that states were on the front lines in responding to the pandemic and we're going to be incurring greater healthcare costs. Also recognizing that Medicaid is cyclical to economic growth. So states are dealing with more people being eligible for Medicaid at a time when they likely have lower state revenues to be able to handle that. So we need to give states more support, more funding to support what is likely going to be an increase in their Medicaid enrollment. It was also a recognition that state budgets generally were going to be under stress because of a drop in economic activity. You'll remember that the craziness of that March in 2020 and the shutdown basically of the economy. So there was a broader recognition that getting money to the states through Medicaid was a very quick and efficient way to support states and to prevent budget cuts. And for those of you who've been working in this business for a long time, you know that anytime there's an economic downturn, that discussion of increasing FMAP comes up. So during the Great Recession after 2008, there was similarly an increase in FMAP. But Congress is not, is not solely a benevolent body. They said, we're going to give states extra money, but we're also going to require you to do things because of it. And they said, we know that you need this extra money because you're going to be seeing many more people in need on your Medicaid programs, but we want to ensure that people have stable health insurance coverage during the pandemic. So if you accept this 6.2% increase in your Medicaid rate, you have to keep everybody who's in your Medicaid program in your program for the duration of this public health emergency ends. It's called the continuous coverage requirement, and it goes to March 18th, 2020. So it's everybody who was in the Medicaid program at the time President Trump signed this into law, or anybody who subsequently joined. So somebody loses their job in May of 2020, their income goes down and they become eligible for Medicaid. They're also being held in the Medicaid. And so what it means is you have to keep everybody covered. You can't do what are the regular redetermination checks and determine somebody ineligible. There's a normal cycle that we'll talk about of people turning on and on. So clearly it's Congress saying, we're sending you extra money because we know you need it, but in order to qualify for it, you have to keep people in coverage. And there was this recognition that meant Medicaid enrollment was gonna go up, and that states were going to be holding people and they would be pausing their normal redeterminations. And so here are some of the key dates and the facts. So the HHS secretary, since that initial one under Alex Azar, and now of course it's Javier Becerra, has been renewing that public health emergency every 90 days. Also what has happened is HHS has said to governors have said, look, we need some heads up so that we can plan. And so HHS has said to governors, and I've just pulled this here as an example, we'll give you 60 days notice before we let it terminate. So the current public health emergency is set to expire October 12th, but we've passed that 60-day notice window. HHS should have let governors know on August 14th, hey, it's going to be expiring on October 12th, and we don't intend to renew it. So given what HHS said, we can assume that the public health emergency will be extended in mid-October for an additional 90 days until January 11th, 2023. Now, maybe when we get to questions and answers, we'll talk about President Biden saying on 60 Minutes that the pandemic's over and what that means for this. But given all of the communications from HHS, we've passed that 60-day notice window. It should be renewed in October, and it should run till January 11th. And in all my work with states, I've been encouraging states to plan to assume that it will expire then. So let me just put it out on a calendar for you to see it, like a timeline. It's expiring, and we're assuming that it's going to be extended. It would be extended in October, meaning then on November 11th would be the 60-day notice. And if they don't say they would hopefully tell states by then, we plan to let it expire in January, not extend. And if it does end on January 10th, 2023, then at the end of the month in January, that continuous coverage requirement, that requirement that everybody be held in Medicaid, that would end. The state can start doing redeterminations. We'll be talking about all those processes. And then the FMAP would end at the end of March. So at least the state gets to claim more Medicaid money until then. But that gives you a sense of the timing. We can go back to it if you have questions. And as I said, Kathy will make these slides available. So I keep saying the stakes are high, but let's like quantify it. So by holding people in Medicaid, it's basically eliminated churn. And that meant we have seen a dramatic increase in Medicaid enrollment. And I'm sure Farah will talk about what you've seen on the ground in Michigan, but nationally, more than 17 million people are now in the Medicaid program than were in it before. Basically, the program has grown by 24%. So I would say that Medicaid has been a really vital safety net program for people to have health insurance during the pandemic. But what it means is that a lot of work awaits the state now when the PHE ends, because they're going to have to go back in and redetermine the eligibility of pretty much everybody on their Medicaid program. And normally the state does that at a regular pace. But here, everybody's waiting, and now they've got to do everybody all at once. So it means a lot of work for states, and I'm sure we'll hear from Farah about how they're planning for that. But also what I mean by the stakes are high is that there's the potential that a lot of people could lose health insurance if the processes, because there's so much it's going to have to happen all at once, that people could fall through the cracks. And I'm just showing you sort of on a graph now that we're at almost 88 million people across the country are in the Medicaid program. This is the latest month for which we have national data. And there are estimates from the Urban Institute and other think tanks and academic experts that they anticipate that 13 to 16 million people will be disenrolled from Medicaid once this process happens. And I think the key question for us today is, where do those people go? It's got to happen in a pretty condensed time. It's asking a lot of states. And the Urban Institute estimates that a third of those people, maybe people whose income has gone up, so they're no longer eligible for Medicaid. They may be eligible for marketplace coverage. They need to go to healthcare.gov. But how do we make sure that they get transferred to healthcare.gov and they actually sign up for coverage? Some of them may have Medicare. They may have aged into Medicare in that time. Some of them may have ESI. So that's what we're going to be talking about today. And this is just reminding you sort of the broader context. Is the good news is that, as I said, Medicaid has been a vital safety net during the pandemic of healthcare coverage. And actually, we are at the lowest recorded rate of uninsurance since we've been recording uninsurance rates. So we are at 8% uninsurance nationally. So the good news is that we are at the lowest uninsured rate, but part of that is because we've been holding people in Medicaid, and what happens next will determine whether we see our uninsured rates go up. And just a reminder on some context is that this kind of churn is very common, that people turn on and off Medicaid. And there are three reasons why people might be coming off Medicaid. One is their income may change. So say you're in a job where your income is not set at an annual rate. It's set depending on the number of shifts you have. So you may pick up more shifts and your income goes up and you're no longer Medicaid eligible. So if there's change in income, there's also change in circumstance, meaning a child may age out of Medicaid, somebody may get married, you may move to another state. So these first two are sort of normal reasons for why people may fall off their Medicaid coverage. It's the third one that worries us, which is that they may be falling off what we call procedural denials. They may be calling off for reasons that are not based on their eligibility. So they may still be eligible for Medicaid, but they may fail to comply with some paperwork requirements because perhaps they moved and they didn't get the mail telling them, they didn't respond quickly enough. So this is the group we worry most about because they are still eligible for Medicaid, but they may be falling out because of procedural reasons. The paperwork may be confusing. So there's a whole number, and there's a whole literature about this, and people may be interested, we can ask questions, but this is where I would commend people to focus thinking about is how do we make sure people, for the first two, it's helping people who are no longer eligible for Medicaid, but may be eligible for different types of coverage, helping them find that coverage. Because if the goal is to help people maintain coverage, it's helping them find the coverage for which they are eligible. So maybe that they're on employer-sponsored insurance, they go over to healthcare.gov. But this group is the one that worries me the most because they may fall through the cracks and they are eligible for Medicaid, but they're going to lose that coverage and then they're going to lose access to care. And of course, with the attendant health consequences. And, just a reminder, this is the biggest healthcare coverage event since the implementation of the ACA. That's how big it is. And it has tremendous equity implications because we know people of color are overrepresented in the Medicaid program. So they're more likely to be impacted by these procedural denials. People of color are also more likely to experience volatility and instability in employment and housing. So we know that, and maybe Farah will comment on this, that the state may have people's addresses from March 2020. There's probably been significant housing instability and people have moved. And so if the state is sending out letters saying, come back in, we're restarting our eligibility determinations, those letters may be returned to them and may not find people. And again, it doesn't mean that people are no longer eligible for Medicaid. The letters just haven't found them. So we've done actually some focus grouping on this and found, and this is public reporting, but I'm also going to show you what we found in our focus groups. People don't know this is coming because people have been held. People have not been getting regular mail about their eligibility because they've been held, basically held, like, they've been held in on pause in terms of eligibility since March 2020. So people don't know this is coming, and there have been a few headlines here. These are just, from national stories I picked up. But we also did some focus groups, and two things stood out to me. Is that one is that people have really valued having their Medicaid during the pandemic. It's been really important to them. So it reminds for all of you who work on these policies how important the program is, that safety net. And it really was important to them during the pandemic, but they also don't know what's coming. So I think, it's important to remind ourselves that for everybody who's on this call, whether you're a legislator dealing with constituent services or you're working for a hospital group, a hospital the hospital association or a hospital system, we all have a role up to play, I think, in helping to communicate to people that this is what is coming. And this is just a resource page we have of a lot of different resources if you're interested in going deeper on a lot of these issues. The federal government has been talking a lot to the states about what to expect. They have clarified to the states what they expect from the states as they prepare for the unwinding. There's a significant federal guidance, and I would just point to a couple. One is that the federal government has required states to develop a plan. How are you gonna do all this work? And I think Farah's going to talk about Michigan's plan. They haven't required the state to make those plans public, but they've said, come up with a plan and we may ask you to share it. And they're going to give states 12 months, or basically 14 months, because they let them start 2 months. They're going to give states about a year to do all this work. And they've said, we don't want you to do it too quickly because we're worried that it's unsustainable. And if you do it too quickly, more people are likely to lose their coverage procedurally for administrative reasons that are not actually accurate. So they're asking states to think about how do you do this over 12 months in a way that maintains coverage and helps people find whatever coverage they should be eligible. And, and they also want states to think about how do you work with, in Michigan's case, healthcare.gov. So there's a lot of federal guidance. So I won't do too much, but they're basically encouraging states to start preparing, to start communicating with beneficiaries. And then bottom right is really interesting. They're really encouraging states to work with community-based organizations or health plans, providers. How do we get consumers ready? They've been doing a lot of calls. Farah can testify to this, I know, with state officials. They're providing technical assistance, and they provided a lot of flexibility states. I'll point you to the second to last at the bottom. There's also going to be a special enrollment period. So whenever this ends, for that 1/3 of the people that we think are going to be eligible for marketplace subsidies, healthcare.gov will reopen for a special enrollment period so that people can go over to healthcare.gov and sign up for marketplace coverage. But I know this is daunting, and I want to pause on a several challenges that I think that I'm seeing across the country that states are facing, and Farah may go mention a couple of these. I mean, it's that, look, the state has faced we're asking the state to do a job it normally does spread out over a year, to do it, sort of all at once at a time when they have the highest enrollment they've ever had. So they've got E&E backlogs. I think that I'm seeing across the country. I don't want to speak for Farah on Michigan, and they have real workforce issues that I'm seeing across the country. There's been a lot of turnover. It's hard to hire, given the unemployment rates now. So I put out a plea for. So I send a lot of compassion to state Medicaid agencies, because they're dealing with a lot of stressors on their own workforce. They're going to be dealing with a lot of appeals. They may have vendors who do some of this work, for example, at a call center, and their vendor also can't hire. But is the vendor ready to staff up for the deluge of calls that are going to come in? So one is this, is the workforce constraints in the state. Another barrier that I've heard from state officials is, the inability to communicate with members, because they've lost touch with them, perhaps because of housing instability and people moving. It's been 2.5 years. Normally, when you're more in touch with your members, you're more in touch with where they are living, and there may be a lot of return mail. And related to that too is, how do you get people's attention when you don't know exactly when this is going to happen? If you start saying to people now, it's coming, but it doesn't happen in January, it's like nobody's wanted to cry wolf. So this question of when is really tough. And then finally, the third bucket, I would say, of challenges that state Medicaid and CHIP agencies face that I think is true in Michigan as well, is you got a lot of different priorities. You may be reprocuring your managed care plans. You've got all these temporary emergency authorities related to the pandemic, related perhaps to things like telehealth. You got a lot going on at the state level, and then this is coming on top of this. So this is pretty daunting for states, but there are some state strategies that they can adopt to help mitigate. Again, I go back to, what is the policy priority? I think here, what I'm seeing across the country, then in the National Association of State Medicaid Directors, they surveyed their members, and they found that the #1 priority for states was mitigating coverage losses, keeping people in Medicaid if they're still eligible, or helping them find other coverage if that's what they're now eligible for. So I'm going to run through some of these strategies at a high level, and then you can come back and look at these slides if you want. A big one is ex parte, and this seems like a very confusing slide, but basically here, the point here is that states should automate as much of this as possible. If you're relying on people responding to mail, that's going to be a problem, because, as I said, a lot of that mail may not find people. But if you can automate as much of this as possible, and you've got reliable data sources, for example, SNAP, it's the second one here under the apple in the ruler. If you've got a different means tested program like SNAP that has very rigorous eligibility requirements, and the state has already determined somebody is eligible for SNAP, what we previously called food stamps, that person is going to be eligible, is likely eligible for Medicaid, and you could automate the process as much as possible. What's the advantage of that? It streamlines it from the state administrative point of view. It's asking less of your state staff, which frees up your state staff to focus on the more challenging cases, right? If you can take populations that are eligible, it also is going to be more member friendly, because you're not asking them to fill out as many forms, because they've already filled out their SNAP form. So this is an example. Another on the left is looking at it. If you can rely on IRS or quarterly wage data to confirm that somebody's income is within the Medicaid eligibility limits, the more you automate that, the less you have to ask of your state staff. And again, they can focus more on some of these proactive strategies. So these are just some of these. We can get into them if you want. I looked at Kaiser data, Kaiser Family Foundation data. This is from a 2022 survey. And states are successful with their use of ex parte to varying degrees as you look across the country. And Michigan's sort of solidly in the middle. The dark blue are the states that have higher rates of ex parte, meaning they're able to automate more. Michigan's in the middle, and Farah may want to comment on where they are, but they're definitely ahead of many other states that are doing very little of this automation, which means they're setting themselves up for a more difficult unwinding because they're not using ex parte as much as I say Michigan is. And we developed a tool that if you want to look at where states can sort of do a diagnostic and see, well, how can we do better? What are we looking at our SNAP data? Are we looking at IRS data? Where are reliable sources of data that we can rely on to automate as much as possible? What are other strategies that states can do? I mean, one, it's got to be you're preparing your workforce. That's a lot of training. I heard from one state Medicaid director who said he has no one on his staff. This is not Michigan. No one on his staff who has ever denied anybody Medicaid because he's had so much turnover that he doesn't have any eligibility staff from pre-pandemic. Another thing that states can do is you can try and time your transitions and time when you do your redeterminations. Maybe you're going to wait to do people who are about to turn 65 so that you can do it in a way that they can then go right to Medicare coverage. You're a state that I think has been leading and thinking about covering pregnant and postpartum women. Is there a way to stage that? I had a slide later on that. But I go back to sort of a key principle is how important it is to collaborate with your stakeholders, because these kind of stakeholders, they may have even better connections with members than the state Medicaid agency has because they haven't been in as much contact since the start of the pandemic. I mean, they have in many ways, of course, but they haven't been doing the redeterminations. So one example is the managed care plans. They may have up-to-date address information because they're dealing directly with a member in their plan. Healthcare providers. I mean, I think a lot of this is, a pharmacist obviously is seeing somebody when they fill a prescription. So they may have an ability to have information where they give people information saying, have you gone back in with the state and updated your address? They may be a point of contact. Other social service programs, like I mentioned, SNAP is a big one. But community organizations too, that are very much organizations that are in the community and trusted, are key partners here to be getting the word out about what is coming. Going back to what I said earlier about people not knowing what's coming, those kind of trusted community organizations, I think, are really important collaborators. Farah's going to go more into Michigan, but I was really impressed as I was looking at, Michigan is one of the few states that's actually published their unwinding plan, which I want to commend them for. So they're being very transparent about their plan, and they've been presenting to stakeholders. So I'm sure we'll see these slides will just sort of preview what we're going to be hearing from state Michigan Medicaid folks, but they've got a website with information. So Michigan is doing a lot of this already, which is great. Here are just some other examples of other states. Arizona also posted their plan and has a website. So this is just, if you want to see, here's California. So just giving you some other big states. North Dakota and Virginia have been doing stakeholder outreach. So if you want to go dig into how other states are doing this, these are examples. And then these are very detailed, but just examples if somebody wants to dig in on account transfer. And here's the question. So I've been talking about how Medicaid stages this and thinks about keeping people in Medicaid, but as I mentioned, maybe a third of the people who are no longer eligible for Medicaid are going to be eligible for the marketplace. So how do you get those people over to healthcare.gov? You are a state that uses the federally facilitated marketplace, meaning you don't have your own exchange. So you're sending people over to healthcare.gov, and those transitions are not always smooth. And so I'm sure the state has been talking to the federal government, and CMS has been trying to talk to states about how they make that easier and make that as seamless as possible. And so the more data that you have on the front end, the more you can send over to healthcare.gov so that people complete enrollment. I'm just worried that they're going to be, stories next summer about people, millions of people falling through the cracks who were eligible. So one way to do that is having as much contact info and data so that when you send a file over, when the state sends a file over to healthcare.gov, they're able to follow up. But we know this is hard, that every state I work with has data system limitations. That makes it hard. So I call it like the perfect storm here, the triple threat of this unprecedented volume, the condensed time period in which we're asking the states to do this, and enrollees being unfamiliar is going to make it, is very hard. So just data. But there are ways, there are lessons about how you can communicate repetitive. Research shows that people need to hear things 10 to 13 times across multiple channels, meaning an email, a text, a billboard, for their behavior to change. So, just a reminder of the need for multiple and repetitive. And for being specific, you might be come back in, update your address so we make sure we know where you are, and clear. And of course, some of these may feel like they conflict. You got to be specific and clear, but we have examples and it's hard. And this is where partners can be really helpful. As I mentioned, hospitals, pharmacies, community health centers, community-based organizations can be really helpful in amplifying these. And I know Michigan has been talking to partner organizations. And we have on our website a toolkit where we sort of have suggestions for how to talk to message to members in a way that is short, simple, but yet specific enough that people know what steps they need to take. And we even have like suggestions for when, like the cadence of when to do it. If you want to come back and look at this, like when to be sending notices, because again, you don't want to be doing it too early, but you want to prepare people. So it's a fine, it's a fine line. And I have a couple examples of Louisiana has been doing a phone campaign saying, come back, update your contact information because we want to make sure we don't lose you. These are just different examples. New York State is running ads in their subway system. What's interesting to me as I look across the country is, of course, states do this in a way that's very organic to their state, and you all know your state better. But there are ways to customize these general principles. Here, just as a neighboring state, what Indiana is doing. So this is just an example. As you look to the left, Indiana is saying, when the COVID public health emergency ends, Hoosiers may lose their Medicaid benefits. Take action now could help you stay covered. So this is just one example. Here are other examples about partnering. So Hawaii has been working with their FQHCs, helping people apply for Medicaid and Marketplace, because people who've been on Medicaid may not be as familiar with commercial insurance. California is using those managed care organizations, and Massachusetts is using community-based organizations. And they're using really locally based, community-based organizations with different language capacities to be reaching different communities. So these are interesting examples if you want to follow up. But before I end, I just want to talk about continuity of care, because I think we get focused on this coverage issue, but there's also continuity of care. And what do I mean by that? I mean, people may go from Medicaid to Marketplace coverage, but they may not be familiar with commercial insurance, and they may be in the middle of treatment. And how do we ensure that they get to continue their treatment? What if you're recovering from an injury or a trauma and your Medicaid benefits are terminated and you go over to commercial coverage? How can we make sure that you continue to get your chemotherapy? You may be getting enrolled in a benefit plan that looks really different. Like you may be dealing with formularies, a different provider network, copays in a way that you've never thought about it. So this is something for state health officials to be thinking about, not just in Medicaid, but in your Department of Insurance. And also, I would say the partners on the outside too, is how do you maintain continuity of care during this really unprecedented transition? So we've developed some strategies, and you can learn more at the hyperlink at the bottom. But one way to do it might be to think about maybe transferring people who are mid-treatment, holding them and doing them later if you can, or identifying particular eligibility groups like postpartum women. And a way might be, as I said, if you delay people, then that gives you more time to do outreach so you don't lose them. There are also some commercial insurance strategies, and this is more for your Department of Insurance, but we've noted 13 states, Michigan is not one of them, that say that if you're mid-treatment, when you switch from Medicaid to a different health plan, that new health plan is required to cover you as with an out-of-network provider. You can continue basically service. You can continue the treatment under that treatment plan in your new plan, even if that provider is out of network in the new plan. So these are some examples, and I'm just doing this at a high level, but you may want to think about is how do you help people maintain access to coverage, to care, even as they switch coverage types. And this is particularly, I think, salient for postpartum women, obviously, like across the country. 750,000, there's been a lot of women who are pregnant, who are now postpartum, who are held in coverage, but we know all the research shows that the maternal risks continue up to a year for pregnancy-related deaths continue up to a year after the delivery. So how do we make sure we're continuing coverage? Here are some ideas for that. And finally, it's a time to think about that coverage continuum, right? Is that we've got sort of the American healthcare system is marked by fragmentation. You have Medicaid if you're up to this eligibility level, then above that, you may get a subsidy on healthcare.gov. You may get health insurance from your employer. If you're over 65, you get Medicare, right? It's like all these different systems. How do we strengthen that continuum so that people get the coverage they need when they need it and for which they are eligible? And, some ideas are Michigan is already doing well in terms of providing 12-month continuous eligibility for kids. So keeping people covered in Medicaid and CHIP. But some states, if I go back again, Oregon is looking at covering kids from 0 to 5, saying we want to cover you until you get to school. And Michigan is also one of the leaders in covering women postpartum for 12 months. But there are other ideas for thinking about this. And I think I'm about at time, actually. Kathy gave me till 12:45. I hope this sort of whet your appetite, a lot of information, but I look forward to, if you have any questions, then Kathy, I'm going to turn it back to you.
Thanks, Heather. Wow. Thank you for so clearly describing the magnitude of the tasks, really, and the urgency for states as we proceed through the process. And for your detailed slides, I think that's going to be really helpful for the folks, especially those that end up watching this recorded, that they'll be able to look, carefully through the slides. So thank you very much. I don't know if this is a fair question, but I'm going to ask it because I don't see any questions in the Q&A right now. But please, if anybody's does have a question, you can either raise your hand or put it in chat. So right now we know, as you said, that we're at least until January 15th with the public health emergency because states have not gotten the 60-day notice that's required. So when we first started planning this session, we had some belief it was going to end in July.
Right.
And we thought the timing was great. And then we knew that folks got really tied up in, finalizing the FY23 state budget. And so we postponed. And now we know it, obviously that there's been no notice. But is there any guess of when the public health emergency will end? Can you share any information on that?
So, Kathy, great question. And sort of, I will tell you, if any of you are following sort of the national health news, everybody's scrambling based on President Biden's comments Sunday night, where he said the pandemic is over. And then people have walked that back to say, well, he means generally we've moved to a different phase. It's, but what does it mean for the public health emergency declaration that is so important? I mean, and this is important in terms of the unwinding of the continuous coverage requirement. It also is a big question for state budgets, right? Like that extra FMAP has been a lot of extra money for state budgets, and how long can you assume it will be in there? I will tell you that the Congressional Budget Office has assumed that the public health emergency will go to next summer. I don't think it will go that long, but it was interesting that the CBO did that. I still project January. And I think if they were to let it expire in October, that would go against everything they've said to governors about giving 60 days notice, and they haven't given that. And that would really, I think, it would open them to charges of being unfair to state budgeting and the states. So my best advice to states is that it will expire in January, and to plan for having to start that work in earnest then. But that means that's not that far off. So all of that preliminary work about softening the ground, telling people that you're going to be coming back to them, asking them to update all that work can be happening now with partners, and a lot of work is happening, I know, behind the scenes at Medicaid. So I would say the best for planning purposes, I would plan on January. Of course, we don't know if the pandemic itself takes a different trajectory this fall, if a new variant comes out, that could change, but that would be my best guess. But I do know that everybody's been scrambling since the president's comments on Sunday night. So that's what makes it so hard for the states that plan.
Yes, I think we were all shocked when we heard it.
Oh, I see Monica's question. Do you want me to just jump in? I had a slide there. I won't go back to it. No, the FMAP continues until the end of the quarter in which the PHE ends. So it's currently, if you assume it's being extended till January, if it expires in January and is not extended, Monica, then the FMAP would go through the end of that quarter, which is March. So this is why, some people thought, well, maybe they'll just end it at the end of the calendar year, but that would be bad for states, because if they ended on December 31st, the FMAP would end at that quarter, which would be December 31st. So by going into January, even just 10 days, it means that the money flows through the end of the quarter, which is March. So as a former state official, I always worried about, trying to get as much federal help as I can. That is a better case scenario. At least then that means through the end of March, which means 3/4 of your state fiscal year. You're a July 1 fiscal year, right?
No, October.
Oh, okay. Well, so then, but at least it would take you through, 2/4 of your fiscal year. Good question.
Yes, good question. And I'm not seeing any other questions. I will just note, excuse me. I have spent a lot of time in the car recently, and I continuously hear the advertisements put out by the department to remind people to keep their addresses up to date, not with sort of a sense of urgency yet. So I'm guessing there are plans for.
But that's great. That's exactly what the research says, is you've got to say it a ton, what did I say, 10 to 13 times before people are hearing it. So kudos to the department to be doing that.
I traveled, to the Upper Peninsula and back, and I heard it, I think, at least 6 times in one of those 6-hour trips for, in different markets as I proceeded. So, okay, very good. Thank you. We will take questions again at the very end if something occurs to you that you'd like to loop back and ask Heather. Otherwise, I will introduce Farah at this time. And I will also mention that we do very brief introductions when we introduce our speakers, but the full bios are listed on the IPSR website. So I'm pleased to introduce Farah Hanley. She is the Chief Deputy Director for Health, overseeing the MDHHS Behavioral and Physical Health and Aging Services Administration and the MDHHS State Hospital Administration. So Farah, welcome, first of all. Thank you for taking time during this busy time. We'll be talking about Michigan's plan. As described, as Heather has mentioned, the states are each tasked with carrying out various tasks, and Michigan's plan will now be presented by Farah. Thank you.
Thanks, Kathy. I appreciate that very much. Thanks, everyone. And thanks for the opportunity to be here with you all today. I'm going to see if I can present my slides. And does that work? Kathy, is that good?
You're good.
Okay, thanks. Again, thanks, everyone. And thank you, Heather. That was immensely helpful, chock full of great information. I don't think I'm going to be nearly as eye-opening, certainly not from a national perspective, but the team has done a really wonderful job helping pull together all of the information for us to share with all of you today. So I want to make sure I catch everything. I'm going to be looking down at my notes and making sure that I caught everything for the presentations. But the goal of this conversation is to just reinforce with all of you that our department is working very, very hard to A, maximize continuity of coverage, and B, to keep the PHE unwind process as simple as possible for our beneficiaries. So throughout the presentation, I hope to really explain to you the work that we're doing to achieve these goals. And just one slide here, a little bit about ourselves. For those of you who don't know, we are the Department of Health and Human Services. We are 48% of the state of Michigan budget and 1/3 of the state employee workforce. Our programs are heavily weighted towards our health programs, although our human services side, I would argue, are equally impactful. You'll see from the slide presentation that 3/4 of the $32 billion in our budget supports Medicaid, behavioral health, long-term care, and aging services, most of which are delivered through our traditional Medicaid or our Healthy Michigan Plan program. Taken together, Michigan Medicaid program is about $25 billion. And the fun fact I like to use here is that that is larger than the worldwide revenue of McDonald's Corporation. So, and I would argue is far more complex and dynamic and fluid than McDonald's. Over 90% of the funding is matched with our state general fund. So our non-discretionary state dollars are really very few and far between. And if you look at our overall programs, they are far and away largely funded with federal dollars. So a little bit about the PHE Unwind. I know, Heather, you covered some of the federal actions that have really driven us to the conversation we're having today, so I'm not going to spend a lot of time here on the slide, but I think the takeaway really is that we're continuing to monitor federal actions like most states are related to the dates when the PHE will wrap up. We're proceeding full steam ahead in the meantime. We do have lots of conversations with our National Association of Medicaid Directors, and we do attend conferences where we continue to hear from national experts like Heather on where we are with the PHE and monitoring federal actions related to it. The FFCRA did introduce several provisions for Medicaid. And again, while they've all been impactful, I think the most notable one is the continuous coverage requirement that Heather noted. I won't spend a lot of time on this. But again, this, as Heather reviewed much of it, it really gives a highlight of what states need to comply with in order to receive that enhanced FMAP rate that we did receive, getting us up to over 70%. This continuous coverage requirement has really had a substantial impact on Michigan Medicaid's caseload growth. If you look here just from 2018 to 2022, for the 3 years preceding the PHE, the annual HMP and Medicaid caseload was relatively stable. You'll see it was pretty flat. Over the last 2.5 years of the PHE, there has been significant growth. It has now hit a record of over 3 million beneficiaries, and that's about a 21% increase from March. So not quite the 24% national rate that Heather mentioned, but still quite high for Michigan. And I've been working on the Medicaid either budget or program or policies for the last 25 years, and I've never ever seen it at over 3.1 million. So we do have our work cut out for us. So we are planning. This tremendous caseload growth really highlights the work that we have ahead and the importance of a thoughtful and deliberate planning process. We have developed several committees that you'll see here on the slide, tasked with addressing the broad actions necessary for the seamless transition out of the PHE. The committees are really focused on the renewals, redeterminations, engaging our partners and our stakeholders, the realignment of the level of care determination, reviewing some of the Medicaid policies, and then finally coordinating with our partners at the Department of Insurance and Financial Services to ensure a seamless transition to the marketplace where individuals would be eligible for that coverage. We do have a number of key activities underway as part of this very large and massive effort. The 3 broad categories do include a review of our policies and reassessing those COVID-19 policies to determine what the appropriate next steps are and what does it look like in a post-PHE world. Planning for the expiration of the continuous coverage requirements, where we are conducting, or will need to conduct rather, a full redetermination of all of our Medicaid beneficiaries. In engaging stakeholders to ensure this broad understanding of our Unwind plan and extending our reach relative to our beneficiary communications. And I'll touch on that a little bit later in the presentation. But the next few slides are really going to elaborate on these 3 areas: our policy review, our renewals and redetermination work, and our stakeholder engagement. From a policy perspective, we have over 100 state of Michigan Medicaid policies that were promulgated during the PHE. They are currently, each and every one is currently being evaluated for each determination, and for each a determination is being made in order to identify how to optimally address the transition out of the PHE. So you'll see that some of them actually will need to be maintained. Reviewing them, it appears that some of them may be beneficial to maintain. And so we're looking at leveraging various authorities that we can in order to do so. It is possible that some of the portions of the policies we have in place would be best modified, where we would actually exhaust some of our authorities and actually building from the lessons learned from the pandemic. So it might require some of the policies to be changed going forward. And then finally, looking at some of where certain federal authorities are actually going to end, and the policies issued under those authorities really couldn't continue under the end of the PHE. So, and all of these things do include a 35-day public comment period and the issuance of a final bulletin. None of these things happen in a underneath a cloth or underneath the table. This is something where we have at least 30 days before the effective date of a policy change as part of the issuance of a final bulletin. And the changes are really made through these intentional and required stakeholder notifications. So we really do a lot of this work in the light of day, and we engage our stakeholders at every turn wherever possible. So here's an example of some of the PHE policy changes that we have considered, and they're highlighted here. With telemedicine, we've had broad flexibilities during the PHE, and that's really allowed for the expansion of some of the applicable services that could be rendered via different telemedicine modalities, including many of the services that were eligible for audio only. For the direct care workforce to alleviate, to continue to support on the recruitment, retention, and training efforts, and to mitigate some of the challenges in that area, we have applied various wage enhancements, designed and administered those. Thankfully, with the support of our legislative partners, received an appropriation for those dollars. With the cost sharing during the PHE, many of the typical cost sharing requirements were actually waived or modified, including the coverage of the COVID-19 related testing, treatment, and vaccinations, all without any copays. Prior authorization is a policy that we've also been looking at. We did obtain several flexibilities associated with prior auth requirements in the early stages of the pandemic. And that really allowed for waivers of the pre-approval requirements or the extension of some of the pre-existing authorizations. We've looked at face-to-face services where certain services in the state plan required that contact, and we obtained some approval to waive the requirement during the PHE. And then things like nursing facility reimbursement, where during the PHE, the nursing facility reimbursement changes were made to address declining resident census. So a lot going on. And again, of those 100 plus policies, these were some of the key changes that we did make. For renewals and redeterminations, we had a strategy. Our strategy was three-pronged, and it was intended to achieve balanced workloads, beneficiary friendliness, and an even caseload distribution. So pursuant to the CMS guidance, we do have a total of 14 months, as Heather mentioned, to initiate and complete redeterminations for Medicaid beneficiaries. It will include our local county offices that are going to be very busy conducting a full renewal of all of our individuals enrolled through auto renewals and requests for information where necessary. It is in addition to the regular ongoing operational requirements, such as processing or addressing any new or outstanding applications, conducting routine verifications, and just general changes in various circumstances. To further actually streamline the work, we are building off of and leveraging every opportunity where possible on the ex parte or the passive renewal process. And again, to leverage that and to build on that wherever we can. Continuing on with redeterminations and renewals, when the PHE ends, many of the individuals who have remained covered in the program due to the federal continuous coverage requirements may no longer meet eligibility requirements. We know that. The department is anticipating the end of the continuous coverage requirements, which will obviously have the largest impact on Medicaid and healthcare systems. So our primary goal, as mentioned, is to maximize continuity of coverage for beneficiaries, whether this is through Medicaid or through the marketplace. And we have partnered quite a bit with our external stakeholders. 2 million of the 3 million Medicaid eligibles and beneficiaries are enrolled in our health plans. So there's been a lot of work with our health plans as well. We did run a small pilot project to understand the volume of things like address changes in order to help with the redetermination renewal impacts. And that pilot really went well because it gave us some information in terms of the volume of address changes that'll need to be made. We compared addresses against our Michigan childhood immunization registry system with our Michigan disease surveillance system and cross-referenced all of those with our national change of address database. So we did learn quite a bit, and recognizing the significant volume of these redeterminations, in addition to the existing workload of the ongoing case management and applications, Public Act 87 of 2021 did appropriate a one-time augmentation of around $21 million that would be in part leveraged to support existing staff reassignments and helping out with new local county office eligibility staff onboarding, staff training, and resources for the PHE related redeterminations. So we're grateful for the legislature's support in those efforts. And from a communication strategy, we really communicate these changes. We're looking to do it in 3 broad approaches, and we know that how we communicate it is really critical to the success of the rollout. We have designed direct messaging campaigns across multiple platforms like social media, text messaging, mail, website, radio announcements, and we've developed resources to support consistent messaging for community partners to leverage and amplify the outreach efforts. There are toolkits and resources that will be available to the department's community partners, regularly updated to align with various phases of the PHE unwind process. Key components of the messaging are going to focus largely on ensuring beneficiaries know it is critically important to do 3 things. 1, keep contact information up to date so the department can reach them. 2, look for and respond to letters from MDHHS in a timely manner. And 3, understand their coverage options and where to go for help. The key messaging is going to evolve as we proceed through the unwinding process, but our current messaging is really focused on ensuring the department has up-to-date contact information. We're going to request individuals update their address and phone number so that we are able to effectively reach them when redeterminations resume following the end of the PHE. We're going to leverage other data sources available to the department to determine when address information may be out of date to conduct targeted outreach efforts wherever we need to. And we know that these are really going to be critically important in order to mitigate that unnecessary coverage loss in churn. I think Heather may have referenced that Michigan is trying very hard to provide resources and information wherever possible. We have launched a public website to help stakeholders stay informed and engaged, and that is up on the slide presentation there. This page contains responses to frequently asked questions, stakeholder toolkit, an informational webinar, and so forth. So our FAQs are actually updated weekly as inquiries are received to the department, and we've had several webinars already with various stakeholders. Additional social media and radio spots are also being leveraged to ensure our messaging is a broad and impactful reach. We've really taken into account the lessons learned from our work requirements communications, and there was a lot of work there, and Kathy was a huge part of that back at the department. We will again be using a human-centered communication approach. We partnered with the Maximus Center for Health Literacy and focus tested our materials to maximize the effectiveness of the PHE related beneficiary communications. It includes clear, simple messages, graphic friendly layouts, and lots of white space to draw and maintain the reader's attention. The draft brochure shown above is an example of the type of human-centered communications we plan to leverage throughout this entire process. So we're excited about the work here, and we really think that between the communications, the work with our renewals and redeterminations, the policy reviews, and really brochures like these that focus on human-centered design, that we're setting ourselves up for as much of a successful rollout as possible. And that's my presentation. Happy to take questions.
Thank you so much, Farah. Amazing work that Michigan's done. It's impressive looking at it from out here. I'm certain it's been a lot of work, and the website is really easy to navigate, and there's such good information there. So thank you. I am not seeing any questions from anyone. This would be a good time if anyone, Arnold, is there someone with a raised hand? I can't tell what that message was. Is
Yes,
there
it looks
anyone?
like Beverton of our staff has raised his hand.
Okay.
Hello, can you hear me?
Yes.
Yes.
I was just wondering, how are we handling coverage or ensuring coverage for mental health patients, or ensuring that they either stay covered, still have access to screening, and do we have a plan perhaps for those kind of folks, for both of those who are, out there, but also those who may be incarcerated, particularly, who may not have necessarily everyday access to their mail to stay up to date on some of these stuff?
Yeah, thanks for that question. I appreciate that. The department has really focused on expanded access to behavioral health services. And I know for one, I spend a lot less time either here at home or at my desk, and a lot more time running around on site visits, meeting with behavioral health providers and advocates, really trying to better understand their needs. We here in Michigan have a Medicaid program where we certainly do cover our behavioral health services. And those benefits are a part of either the traditional Medicaid health plan services or are part of the community mental health services programs. And we continue to have really intentional conversations and outreach with our community partners to help with the transition. So if an individual is actually enrolled in Medicaid and they do have some behavioral health condition, that service will go with them, that benefit will be with them when they maintain coverage through Medicaid. If they qualify for the marketplace, we are working really closely with the Department of Insurance and Financial Services to get them to transition to the marketplace, and hopefully have a plan that will then also cover them there. So to the extent that an individual does have a mental health need and they are enrolled in Medicaid, they would maintain that coverage would continue. I think that there's a lot going on in the behavioral health space right now, and this PHE piece is one of them. So again, that's why I very much appreciate the question. We have a lot of issues we're seeing. I like to say the pandemic didn't really reveal crises and concerns, it actually exacerbated it. And so we're working through how best to address some of those. And I think one of the biggest problems we're finding is not so much that people won't get coverage, it's when they have coverage, getting them service. And that service is usually an obstacle, largely because of the shortage of our direct care workforce. So we have a lot of workforce strategies, so it's all, as I talk, I can hear myself going from one thing to another, but that's because it's Medicaid and one little thing has a tidal wave of effects. And here we are talking about so many pieces. So I appreciate the question. I think, again, this is a matter of making sure that when people are enrolled in Medicaid, they will continue to receive their behavioral services. One of the focuses we have, though, is really expanding access to behavioral health services, which is a little related to the PHE and a little outside of it.
Thank you both for that. Any other questions? Well, I am not seeing anything. I would like to take this opportunity to thank both of you for the wonderful information presented today in such a clear way. There's a lot happening and there's a lot at stake. So we hope that the folks that were able to join us today feel like or have a better understanding of what's going to impact Michiganders, actually citizens all over the country. But what we're most concerned about at this point is Michiganders. So thank you both for helping with that today. And we look forward to all of the good things that Michigan is preparing to hopefully reduce loss of coverage for those enrolled in Medicaid and CHIP. Any other questions? I'm going to one more call for last questions. Otherwise, we'll sign off today with another thank you to the Michigan Health Endowment Fund for their support of this series.
Thank you.
Thank you.
Thank you very much.
Thanks, everybody.
Thank you.
Thank you.
Bye.